So we've got a reasonable period of time now for questions, and I sort of start them up for no particular reason other than to give you time to think of things, but I'm sure you'll all warm up. Kayleen, a question about Mawson. I know Capital and Coast not in the first cohort now, but when Mawson comes to Wellington, how will a surgeon like Nigel Willis get involved in simulation, in this fancy orthopaedic simulation that I'm coming up with? Will he have to volunteer? Will somebody tap him on the shoulder? You know, how will it work for surgeons?
Thank you, Ian. The intention is that that'll be driven by the hospitals, and what we're finding with the first five hospitals is that they're finding their own solutions. So some of the DHBs are planning to do this, I hate to say, on a Saturday or on a Friday afternoon if they've got listed shut down. The real winning goal thing is actually to advertise early, and so making that part of what your training is going to be in the future is actually what they're looking at doing. So the advertising actually starting in some of those DHBs already, so people can block time for training. Yep.
And I see you're sitting next to Paul Manuel over there, and so when is Masterton going to be on the list?
I'd have to look at my slide again. Cohort 2. Yes, we've just written to them very soon. So we intend to visit end of this year or early next year, and the training will be at Masterton by the end of next year.
That means there's be about one sim man per doctor in Masterton, won't there?
Pretty much.
All right, who's got questions for the group? Anything on briefings? Yeah.
Thanks. Hi, I'm Jeff Anderson. I'm an orthopaedic surgeon from Palmy. This may or may not please you because you mentioned you thought you were preaching to the converted. There is at least one cynic in the room. My concerns with the whole process of briefings, debriefings, and whatever is it has a great tendency to become a meaningless ritual. The point's been made a few times that there's no point in having a debriefing unless the points you actually raise get actioned. And equally, you can't have a team briefing unless you've got a team. And I'm very fortunate. A lot of the time, I work with the same anaesthetists, the same nurses. I have great team atmosphere. I believe a great team atmosphere in theatre. And those lists are smooth and low stress for me, and things tend to go well. Other days, it's not a familiar team, and my, if you like, level of listening to the rhythms goes up quite a bit. But the point I wanted to try and make is with the really good team, you hardly even need any of this stuff. And if you haven't got a team, it doesn't work. And I was wondering what your comments would be about that.
I sort of totally agree, but I'd extend it differently too. So one of the things you're looking for, and Kathy was looking for, was some ordinal outcome to the process. And I think, as Ian started off saying, there's difficulty looking for data because there's an element of social cohesion. And I totally agree with you, and I brought it up in my slide, that stability of a team is as important as anything in the safety culture of theatre. But in reality, I live in a really good and small community theatre, and my team's different every day. So I want to make sure that I can support that, and there's the social cohesion that a briefing can give for a team that isn't familiar. And for a team that is familiar, it is a sort of reinforces that social cohesion. You know, one of the questions I had for Kayleen is, I think that Mawson looks fantastic, but the inference is it's aimed at a coherent team to get the best out of it, and I just don't have that. I don't have it in public, I have it more in private, and I certainly don't have it when I go to the regional hospitals. And so my question would be then, in the same vein to Kayleen, what is the inference of the program? Is it so that there are people who are trained within the DHB to then spread the word, or is it aimed at a cogent team?
I think you're right about the DHBs, that they're all structured quite differently. Some teams in the bigger hospitals have a group of people that do specifically one discipline. So for those people, it'll work very well. The nurses will have, and just by numbers, a lot more opportunity to come to Mawsome. And really it's about creating a critical mass of people that know the language. They know what they're looking for about shared mental models and the importance of that. So a lot of these things, even the briefing you're talking about, people are doing them and it's almost lip service, but understanding the real importance of that, about sharing the mental model and creating a safe culture is what the message is.
And just from an orthopaedic point of view, there's this reliance that surgeons often have of being a little bit passive, not you, being passive, especially in the DH, that things get done around them. Oh, someone else should have got that implant sorted out. So one of the things that I've picked up several times at a briefing is implants not being available at 8 o'clock in the morning, or the incorrect implant. So perhaps if you've got a cupboard full of everything you could ever want, it's fine, but often that's not the case. And so there are things which you can tangibly identify first thing at the morning, which can have a significant impact on the rest of your day.
Only if your team actually knows where those things are and knows they're there.
True.
If team who don't actually know what's in the store cupboard, debriefing is a waste of time. And I'm sorry, but that does happen.
And I would hope, though, that that's balanced by the quality of your team. And, you know, I maybe am lucky, but the quality of the people I work with is extremely good, and the standard. And so if they don't know something, that gives them the ability to find out.
Let's have a question here from Paul, and then Cliff has a comment as well.
Hi, Paul Manuel, Wairapa. Just from a community rural point of view, I just want to make some comments. Thanks to all the speakers for their input as well. But I find personally that the value of the briefing in a setting where, you know, in a bigger center you have set teams of nurses doing whatever specialty, but I'm a general surgeon, so, you know, I don't have that luxury. I have different staff going, you know, doing endoscopy, and then they go do ortho, and they do general, right? And I find that, you know, the time I take in the morning to do the briefing actually gives me a sense of, you know, what I have to work with, and then I can guide them through it. And it's just something I was trained to do, and I think that this is where we can try to get surgeons to buy into this, is like, you know, we should all as surgeons have, you know, situational awareness. You know, that's part of our job, and part of that is to, you know not only know where our circulating nurse is, or what the scrub nurse is going to give us, and what the anesthesia machine's, you know, beeping or what have you. It's like, you know, the briefing and at the end the debriefing helps us to get that, you know, to stay on top and actually own that part of the theater where, you know, you talked about interdependence instead of independence. I mean, this might be, you know, part of a surgeon's way of exerting their independence as well in that way, is that, you know, look, I need to own situational awareness. And that's how I go about my business with regards to this briefing and stuff.
Cliff, do you want to make a comment? And then Nigel, I think, had a question.
Well, no, it was more a comment, and actually I'll just reflect on what Paul said. You've used the term situational awareness. You could use the term listening to the rhythm. Now, to me, they're synonyms. The reality is that we all work, even in big centres, with an enormous number of people with different skills. The concept of a team and my anaesthetist and my scrub nurse and my tech, it really doesn't exist. So a lot of these systems, to me, are there to help us manage in these somewhat risky environments. And if we ignore these types of systems, and there will be other systems developed over time, then we don't manage the risk. It's all about managing the risk, absolutely, I think. And so that was my comment.
I mean, I think you could reflect on that both ways. Of course, the rare situations that exist now where people have always the same people, it carries its own level of risk because of assumptions about knowledge that may not exist. And if I was Bob Henderson, I'm sure I could ask him to stand up now and talk about his airline crews. However often you fly, have you flown with the same crew? And he, as a pilot, says, I have virtually never flown with the same crew. In fact, he set me up yesterday and acted as if I was his co-pilot, and he went through a briefing with me to determine whether I knew what I was doing, which I clearly didn't. But I said, look, it's got 2 engines, we'll take it off. Cliff, I think a comment, and then John.
I'll just make a quick comment. Although in the airline it's John Crisp, I'm a surgeon in Palmerston North. Your analogy of the airline is good, but they are all briefed and certified for that machine. And they're often the crew and the...
We're all certified to work in the operating room, aren't we?
No, but you may be in a theatre for orthopaedics with nurses just qualified in something else. So that's the difference. I mean, you're not going to get on a 737 with someone who's certified for a 737.
No, that's true, and I don't want to get into where nursing qualification area, which I think I'm not... But I think I'll come back. I'll try and divert that now and see what Cliff was going to have to say, because it probably relates to about 2 questions ago.
No. I think this is all the same conversation, and you're right. Situational awareness, listening to the rhythm, understanding when you've got a good team and you know you've got a good team and when you don't have a good team. They're all the same thing. One of the advantages of the briefing period is you can identify that across the whole team that you're working with. You might have most people who are good and you know them, but there might be a new person. We heard about the nurses from overseas who don't want to speak up. There are a whole lot of things that you don't know about if you don't have a quick but reliable format of making a team before you start the place, whether or not they were there yesterday or every day or they're brand new. And that's the importance of the briefing session.
Just a very brief comment. I'd much rather find out at the beginning of a whole list that I've got an inexperienced team than to find out halfway through one of the operations.
Yeah.
Any comments? Yeah, nursing comment, I think.
Just from a nursing point of view, I think the briefings are so much more important, especially if you've got nurses that you're not used to from a different team. Like, I don't do orthopaedics, but if you've got a bit of equipment that you know you need at the beginning of the operation, and I don't know that, I might not have it ready, whereas at least if you have a briefing and you tell us that at the beginning, then I've got time to seek advice and ask the charge nurse where I could find it, or one of the other nurses, instead of being in a frantic rush when you decide you need it, and then we don't know where to find it. So it actually makes things flow better. And that's the best time to have a briefing, is if you've got inexperienced people, because it gives us a chance to even out those things that could go wrong throughout. And having come from Hutt Valley, I have kind of been banging my head against the wall a little bit since I came to Mid Central, because not having a briefing, there's so many times that there's equipment that we don't know about until the last minute, or the patient positioning and things like that slow things down, whereas if we'd had a briefing and discussed all that and communicated at the beginning, things would have run a lot more smoother.
Okay, useful comment. And a question over here. I hope not engendering World War III here.
That's right. Just again, from a nursing point of view, I do orthopaedics. I do a lot of orthopaedics, and I work mostly with the same surgeons. However, sometimes I find that familiarity breeds complacency. They think I know what they want, and maybe I don't. And if they've decided to change tack for an operation that they've done many times, but they don't want what they usually have, I don't know unless they tell me. I don't have ESP, so a briefing in the morning is really good for us.
And I'll just give you an example, just a contemporary example from yesterday. I was the assistant to one of my colleagues doing aortic aneurysm surgery at the Mercy, and he said just before we're getting underway, he said, "Now, have you got the grafts in the room?" And they said, "Yes." "What grafts have you got?" And he had a look, and yes, there was a 16 straight and an 18 straight gel soft graft. And he said, "And you've got the bifurcation grafts on the shelf, haven't you?" And the nurse said, "No. OBEC stopped stocking them on consignment because we don't use them much anymore. So no, we don't have any bifurcating grafts." And the surgeon and I looked at each other and we said, "Well, I guess that means we're not doing a bifurcated graft then, doesn't it?" And we could have got ourselves into a situation that would have then said, oh God, this is terrible. We planned to do a straight graft, but now we've got to do a bifurcating graft, and we've done all this. Can you get a graft off the shelf? Can I have an 18 by 9? And we would have had to get consignment stock. We'd have to get stock from the supplier, which we could do, but it would take an hour. And when you've got somebody's femoral arteries clamped off, you don't actually want to take another hour. So, yeah, it didn't come to that, but we knew because of the briefing that we were going to have to do a bifurcated graft. It also exposed, perhaps, I didn't perhaps flag it in one of my slides, but it came out in some of the discussions about timing for complex, like some orthopaedic and other prostheses on the morning's not good enough. Because even if we had said, oh, well, that's no good, we'll have to get a graft in, we may or may not have had it available by the time we need it. And you can make cases sometimes for briefings to be done, different sorts of briefings. That one of those groups talked about horizon briefings and briefings that I've heard at previous sessions like this where people talked about briefing the team for their next week's list. I'd love to work in an environment where I know what I was doing next week, but anyway, that sort of briefing that perhaps allows those things to be dealt with. Any other comments?
Ian, can I just...
Yeah. Oh, you got it. Yeah.
Just make a comment about teams, because leadership is not about the leader alone, it's about the whole team. There's a very good book that's worth reading called Stronger Teams, How Teams Grow Together by Simon Hartley, who's an English journalist and psychologist, sports psychologist. And he examined how teams in the English Football League worked and didn't work. But he extended that to other teams, including the Red Arrows, the Air Force team, and including, believe it or not, the rugby teams. And in doing his research, he actually asked Clive Woodward, the English captain, what it is that young men want to be in England when they're growing up. And he said, oh, that's simple. They want to play for England. He then asked the New Zealand coach, I'm not sure which one he asked, what New Zealanders want to be when they grow up. He said, oh, that's easy. They want to be an All Black. And there's a huge difference between those two approaches, because the whole culture, the whole being of the person was wrapped up in being an All Black. And you know better than I do that that's true. Well, maybe I know it really badly because we see it in the way you perform your football duties. If you ask the Australians what they want to be, I think they'd say, we just want to have a good time, which they do, on and off the field. And he goes on to explore it, and he comes across, pardon the French, but he comes across the New Zealand rule, which is known colloquially within the team as the no dickhead rule. And if you're a foolish person on or off the field, you don't become an All Black. What we need to understand that in the complex environment of healthcare, we want people to be the best possible nurse they can be, to be the best possible surgeon they can be, to be a team member. And then that team grows stronger together, and it's got a much greater chance of winning consistently. It's a book that's well worth reading, and it'll take you into a few other books as well. Stronger Together by Simon Hartley.
All right. I mean, those comments, I think, should resonate with us. I'm glad Cliff didn't use a cricket analogy, because we might be on slightly weaker ground, those of us on this side of the ditch, if he did. I think one of the challenges from today is to think about, if we all are largely supportive of the concept of briefings and debriefings as they apply to team activity, then how should we approach this in areas where that's not routine? And I'm thinking that there are potential ways, engaging certain members of the team and request to have a briefing, have a briefing and then and mention to others, well, we've had a bit of briefing, can you add any other information? Something that tries to flag the activity as being something that the majority of the team feel valuable, to try and pull in the one or two people that maybe don't or haven't as yet contributed. I'd like you to take away from the session not only your own enthusiasm, because clearly you have that and you have listened to this process, but what can you take out of it? That I'd love if my hospital was like Hutt Valley, and hearing it, both from people that used to work there. So I mean, I take your comments as being very supportive, because they've got a vested interest in saying how great it is, but you actually were there and reflecting on it. I'd love my hospital to not have 20% of briefings, but 80% of briefings, and I just at times wonder, why the group that don't do it just can't see that the effort. And I know it only takes 3 minutes. I mean, if the video that you've ever watched of me doing a briefing took 4.5 minutes to do a nominal 4-case list, but it takes me a lot more than 4 minutes to actually get the people in the room. And it is quite a struggle at times. Maybe you've got champions. Maybe you've got some champion anaesthetists. I tell you what a champion anaesthetist can do if you want a briefing. The champion anaesthetist can just sit there and say, well, I'm sorry, I'm not sending for the case until the surgeon comes and does a briefing. How do we know, do we know what the surgeon's plan is? I'm sorry, I don't know. I mean, that's a slightly contentious way, a slightly aggressive way of doing it. It's not the pragmatic way. I mean, I feel I've had a bit of a 360 from Chris. I've been criticised before. I don't think I'm too sort of rigid about things, but it's not the first time that people have made that comment about me. So maybe that's rather too rigid an approach, and we should have a slightly more pragmatic way. But the challenge I put out to you is go away from this, not only with your own enthusiasm and knowledge of what's right, but how can we make this process work in our organisation and make it better for the teams and make it better, obviously, for the patients. I feel exhausted. John, you've got another comment?
If we really think the briefing is an important part of the surgical process, and I'm pretty sure it is, given the difficulties we face with the fluid situations and changing patterns, you certainly have to see it as the first part that you do in the list for that day. So the concept that the briefing, in a management sense, is something that happens before the list starts is just fatuous, and that has to go. And the list starts with the briefing.
That's right.
I guess I would just make a comment, and John's comments reminded me on the difference I see when I do my briefing in a private list versus a public list. And I guess I've got the two extremes. I work in a relatively small private hospital, not tiny, and a relatively big public hospital. So in the public hospital, I do the 8 o'clock briefing, which is the earliest that the nurses can get there, the anaesthetist's there, drag my registrar there, do the briefing, I've got changed. Then I go away and do stuff. In fact, usually the registrar and I, we walk out from the briefing, we look at each other and we say, what do you reckon, 45 minutes? And we have this sort of bet with each other about how long before we'll need to be back in the operating room. And generally, it's about 45 minutes because anyone, the patient's got to come from Africa somewhere and all that sort of stuff. Usually they're in order, but it just takes forever. The private is quite different. In the room, walk in the room changed, having seen the patient, say, well, shall we have a briefing? Everyone's really enthusiastic, want to know if there's anything special about the day that they wouldn't otherwise have anticipated. We do that, takes the 3 to 4 minutes, and we say, all right, shall we send for the first patient? I just sit down in the room and look at some paperwork for about a minute or two, and then the patient's in the room and we get underway. Almost, and you will all work in environments which are somewhere between those extremes, I imagine. And in fact, how you schedule your day and how it works will depend on that environment to some degree. Cliff, I think I should ask you to make, I know we've got, we're almost up for time and I sense that we're out of questions. I just wondered if you wanted to make some final comments, inspirational comments to backdrop my rather non-pragmatic sort of ones and see what people would like to take away from the day.
Look, first of all, I think the real message is that it begins here, it doesn't end here. That we take the lessons that we've learnt from each other around safety and quality, about leadership, about protocols, about briefing and debriefing, and we look at how we apply those, and we look honestly and reflectively in our own environments, and how can we make it just a little bit better for the next person to follow. And I think that that's where it starts. We're not going to solve the world by putting an edict out on briefings this afternoon, but we will make huge changes if we say to people, think carefully about how you are progressing towards a better world. And briefing and debriefing, and they're very different, and Bob Henderson talked about that yesterday, and the illustration that Ian gave is a very valuable one. They do it all the time, and they've made a very safe industry. We need to understand that very often management throws up the resource constraints and says we can't afford to do that. We have to have an argument that says we can do that because it's safer, there is less reoperation, there is less readmission if we get it right the first time. Toyota know full well that the worst thing you can do is to interrupt the production line and rework anything. And we don't think twice about taking a person back to the operating room. And we know we have to, they're bleeding, we better get on and fix it. But do we stop and think, well, could I have avoided that? Could my team have helped me avoid that problem and reduce rework? Similarly about patients who go home not quite right and bounce back in 2 or 3 days later, significantly unwell, if not catastrophically unwell. And we can improve. And we can say to our managers, look, if we do this, we can reduce the impact on your budget. But we can go further than that, and we can show them that quality surgery, quality care is actually cheaper care. And we need you to invest in those processes and in those people who can do the job to the best. If we'd adopted the aviation model to investment, it would look something like this. In 1934, Qantas started flying what was called the kangaroo route between Sydney and London. Kangaroo route for two reasons. One, it was Australian. Secondly, there were 17 hops on the way through. It was done in Sunderland flying boats, okay? It cost the equivalent of 18 months of a middle manager's salary to be able to afford to do that flight. Okay, they didn't have first and second class in those days. So 18 months, middle manager's salary. Roll on now to the A380, which carries 300 plus people every time it flies. It does it in the space of 22 hours, including a stopover and a bit of a break. It does it with multiple people in the cockpit. It does it with lots of people as hostesses and train crew in the cabin, with all the technology in the world, which costs the earth. But how much does it cost the passenger? $1,000, $2,000 if you get a good deal. Okay, on average, Qantas say that it costs around about 1 week to 1 month's salary for a middle manager, not for first class, but for a good premium economy flight. So they've reduced the cost because they've been able to do so much more, because they've used the investment to produce a product that the community flocks to buy. And we need to think about that in our healthcare. People are getting sicker, they're getting older, they're getting frailer, they've got more comorbidities. We can't sit still. We have to invest in better ways of doing things, quicker, more efficiently, more safely, without readmissions, without reoperations. And we can change the world. It requires leadership. It requires a lot of communication. Yes, there'll be some argy-bargy about that, but we've got to come together as teams, which include management, as I've said this morning, the operating officers, the financial officers, the executive arm, and indeed the boards, to support a new approach which is based on the fact that the best way to do things is a quality way and a safe way. Together we can and are changing the world. Healthcare has changed dramatically in the last 50 years and more dramatically in the last 10. So let's keep going.
Well, thank you, Cliff. Thank you for attending. Thank you, Kayleen and Liz and Craig and Chris, for giving your presentations and giving us some insight into how things work in your hospital. I hope this session has been useful and allows you to take something away back to your own organisation. So thank you very much for your attendance.